thank you very much. It's a pleasure to be back in Chapel Hill and at this great conference. I almost said Raleigh. I was thinking of the airport. This is the last time you'll have to see this picture of Hopkins. I'm moving to Santa Fe this summer, so next time if they invite me back, it'll be a very different picture. But I'll keep showing the Hopkins picture as long as I legally can. So I was asked to give, I think the title was Drug Update or ART Update, so I'm really going to focus on drugs. And I'll say very little about when to start because it's kind of a subject that gets talked about to death, but I can't resist just saying a little bit about it. So we'll spend very little time. But here are the new guidelines. So the DHHS guidelines have been they've really been giving the same message now for a while, but trying to simplify the language because there had been so much confusion about the original wording. So what they say is, and I think it's pretty clear now, ART is recommended for all HIV patients to reduce the risk of disease progression. And then they go on to say that the strength and the evidence behind that recommendation is based on CD4. So the lower the CD4, the stronger the recommendation and the greater the evidence. Then they go on to say that ART is recommended for HIV-infected individuals for prevention of HIV transmission. Again, strength and recommendation based on risk. So the highest evidence is for heterosexual transmission and perinatal transmission, but it's assumed that the data apply to all risk groups. So those are the DHHS guidelines. The ISUSA guidelines are very similar. They say that ART should be offered regardless of CD4 count, again with the strength of the recommendation based on CD4. And then like the DHHS, which discussed this in the text, they go on to list some conditions where they're sort of saying everybody should take ART, but these people should really take ART. In case you didn't believe our first recommendation, these people really need it. So that's pregnancy, HIV nephropathy, HBV, HCV, older age, and acute phase of primary infection. So US guidelines are all pretty much in agreement. The rest of the world is not. European, British guidelines have not jumped on this bandwagon yet, in part because their guidelines panels have to consider cost. They have to consider the effect on their country's economy. They have to consider the effect of HIV treatment on the treatment of other diseases. In the US, we have this sort of luxury of being able to sort of ignore those things, and that's partly the reason for the difference. I think if you ask most experts who live in those countries, if you had HIV at a CD4 of 800, would you start treatment? They'd all say, oh, absolutely. But in terms of writing guidelines, they have to consider these other factors. So why have we abandoned Oh, I thought I had a test question in there. No? Did it go away? Oh, it's afterwards. So why have we abandoned CD4 thresholds? There's a few reasons. Normally I show the data behind all these, and this time I'm not going to do that. I'm just going to kind of summarize it. One is that we have observational data showing improved survival in some cases, such as NA Accord, or at the very least, studies showing no harm to early therapy. Not all studies have shown the same improvement in survival. In most cases, they've shown some sort of clinical benefit, such as decreased AIDS-free survival, or prolonged AIDS-free survival, for example. But not all of them show an overall decline in mortality. So there's some controversy there, but many would point out that none of them have shown any harm to early therapy. I think there's a growing interest in this idea of copy year viremia, which is looking at the amount of virus a person has over the course of their infection. So they could, if they've been 15 years with a viral load of 30,000 or 3 years with a viral load of 500,000, that gives you a sense of sort of area under the curve, if you will, or the kind of the sum total of the duration and magnitude of viremia. And this has been associated with things like lymphoma and with mortality, independent of what your CD4 is, suggesting that there's more to HIV morbidity and mortality than just being immunosuppressed. It's an issue of ongoing viremia. And presumably the mechanism that causes that to be a bad thing is that it's an inflammatory state, it's a state of heightened immune activation, and this leads to a lot of complications independent of OIs and the traditional problems that occurred with HIV. And then It's also worth pointing out that in a lot of studies, if you start, the Cascade is a good example, the Cascade study from mostly from Europe. If you look at the difference between starting people at 500 and starting people at diagnosis, it's about a year's difference. If you look at the difference between starting people at 350 versus starting people at diagnosis, it's maybe 4 years difference. We're not talking about big, huge differences in the amount of time people are on ART. So both from a cost standpoint and from the effect that it has on the individual's quality of life and things like that, it doesn't really amount to much in the grand scheme of things. We're looking at putting somebody on treatment for many decades. And finally, of course, prevention. And we know from HPTN 052 that this is the most effective form of prevention that we have available in terms of the percentage of reduction in transmission. So with all that, let me just ask you, and be honest now, don't base it on what I've just said. Tell me, as of yesterday, with patients who are willing to be treated, when do you typically recommend starting ART? This question should have gone in the very beginning. CD4 less than 200, CD4 less than 350, CD4 less than 500, or at any CD4 count. So I get to watch the votes coming in. It's like microwave popcorn. When they start to slow down, that's when you stop. Okay, so looks like a lot of you have adopted the new guidelines and are starting at any CD4 count. That's great. And there's a smattering for the other ones, but it looks like for the most part people are adopting the new guidelines. Just another thing that doesn't quite fit into any category, but I thought I'd bring it up, and that is the issue of CD4 monitoring. So there's been some interesting studies and also editorials about the need for CD4 monitoring, and frankly, and if you take care of a lot of patients, you know this to be true. If a person's viral load is undetectable, you don't really care very much about the CD4. The patient tends to care more than you do because you know that what matters is virologic suppression. And so there was a recent study from the VA where they looked at patients who had undetectable viral loads, and they found that if their CD4 was consistently above 300, they were extremely unlikely to have dips below 200, which you could argue is where you might intervene. And they concluded that in clinically stable, these are the guidelines now, in clinically stable patients with suppressed viral load, CD4 count can be monitored every 6 to 12 months instead of the every 3 to 4 that I think a lot of people have been doing. And it's possible we'll even move to less frequent monitoring. Some would argue that in people with CD4s that are in the normal range with undetectable viral loads, the only time you should ever get a CD4 count is if their viral load stops being undetectable. CD4 counts are not terribly expensive, but if you add it all up, it amounts to money that, for a lab test that we don't really do much with. So just something to keep in mind. All right, now let's move on to what I'm really supposed to talk to you about, and that is drug therapy, and I'm going to spend most of my time talking about the initial regimen, because that's where we have a lot of new data. And let's start with a question. So in a patient with no baseline resistance, CD4 450, viral load 83,000, no comorbid conditions, likely to be adherent. Do such patients exist? Yes, they do. Which combination are you most likely to prescribe? Now, CME police don't let me say brand names on slides, but I am going to sneak them in just to make things a little clearer. So the first one, I'll never say them again. You heard it here once, never again. First one is a tripla, Complera, Stribild, and then the rest they have brand names, but they're not combined. So go ahead and vote. What are you most likely? In other words, it's just kind of your default regimen when everything is fine. What would you use? No, cost doesn't matter. Sky's the limit. Insurance will pay for everything. The patient just says, whatever you say, doc. This is a male. All right. Looks like we got enough. So looks like if the efavirenz, a triplet combination, is by far the most popular. A little bit of elvitegravir combo, and it's just kind of a smattering of the others, all right? So let's talk about, we're not going to talk much about this particular combination. We're going to talk about sort of the newer things and where they stack up. So here are the current DHHS guidelines. Haven't changed too much. The four preferred regimens are shown there. They all include tenofovir FTC with either efavirenz, boosted atazanavir, boosted darunavir, or raltegravir. And then there's a list of alternatives that include the abacavir 3TC combinations, as well as rilpivirine and elvitegravir. And ISUSA guidelines are very similar. The main difference is they have moved abacavir 3TC into the preferred, well, they don't call it preferred, they call it recommended category, with some footnotes about high viral load and cardiovascular risk. But otherwise, quite similar. Rilpivirine and elvitegravir are still on the alternative list in these guidelines as well. So let's go through sort of the more recent data, starting with NNRTIs. And I put this in more, not to talk about so much as just to have it for your reference. These are the NNRTIs, some comments about them. And then when I'm teaching fellows, it's very easy for us old-timers who were, around with each new drug that became approved. You could learn those drugs. You didn't have to ever learn a bunch at once. But I do feel sorry for people starting out in the field or fellows who are faced with this huge list of drugs and are just overwhelmed by the number. So to make it easier, I always gray out the drugs you don't really need to know about. So in this case, with all due respect, let's face it, not many people use dolaverdine. If you have somebody on dolaverdine, that's great, but it's something I would advise a fellow that you don't have to commit to memory. So, rilpivirine. ECHO and THRIVE was the first study to compare efavirenz and rilpivirine, not in their single tablet formulations, but as separate components. And you can see that the overall analysis was just a spot on, 78% in each arm undetectable at 1 year. Now, if you look at the details, they weren't the same. So especially in patients with high viral loads, you saw more people experiencing virologic failure on rilpivirine and more people discontinuing due to adverse events on efavirenz. The numbers, added up so that the overall result was the same, but the reasons for failure were different. Rilpivirine had more virologic failures, more non-nuke resistance and nuke resistance, and people who did fail rilpivirine with resistance often got a 138K mutation, which causes cross-resistance to etravirine. Efavirenz had more adverse events, the usual ones you'd expect, and more lipid changes. Now, some people argued that that was kind of an unfair study because people were taking multiple pills, and some had to be taken with food and some without food, because rilpivirine needs food, efavirenz has more side effects with food. So they designed a head-to-head comparison of the single tablet regimens, the rilpivirine regimen and the efavirenz regimen, open label, non-placebo controlled. And here again you see very similar results, very little virologic failure, and in fact numerically there was even a slight advantage of rilpivirine that didn't achieve statistical significance. However, again, if you look at the effect of baseline viral load, you kind of see this suggestion that efavirenz is pretty rock stable at all viral loads, whereas with rilpivirine, 89%, 83%, 72% as the viral load gets higher. And if you look at resistance, with rilpivirine, 2%, 8%, 19%. So it's kind of suggesting that there's still this kind of a dose-response relationship between baseline viral load and failure. And for that reason, rilpivirine is recommended in the guidelines only for people with viral loads below 100,000, where it's performed extremely well and is very well tolerated. Remember, it has to be taken with food, with a meal, really, and not with H2 blockers or PPIs. It's been a popular drug to switch to. This is the SPIRIT study where people on boosted PIs were randomized to either continue their boosted PIs or to switch to rilpivirine. They did well with the switch. Interestingly, 17 had a transmitted 103N mutation. We're allowed to enroll in the study. All 17 maintained suppression. Not surprising because we don't think 103N affects rilpivirine, but it was reassuring. And also it's important to note that even patients with high baseline viral loads obtained before they ever started treatment did well with the switch. This is actually one of the first studies that suggests, but doesn't prove, that maybe once you're suppressed, your baseline viral load is less important than it is when you first start therapy. Here's another a study switching from efavirenz to rilpivirine. These were all virologically suppressed patients, and they found my favorite, this is my favorite pie chart of all time. 100% were suppressed. Some people use histograms for this, all different ways of showing the data. It's very important, though, to remember that these people were suppressed, and we wouldn't recommend that you do this with somebody who's, say, just started efavirenz 2 weeks ago and is having bad side effects, because there are drug interactions between efavirenz and rilpivirine, and we don't know whether if you made the switch while they're still viremic, that those interactions could be detrimental. So this is really only for suppressed patients. You want to see my second favorite pie chart of all time? Here it is. Pie I have eaten, pie I have not yet eaten. Okay. All right. So, integrase inhibitors. Here they are. I don't get to gray any of these out because all three are important. Raltegravir, elvitegravir, and soon to be approved dolutegravir. Somebody in this audience may know what the brand name will be, but I certainly don't, and I couldn't tell you if I did. But that should be coming soon. So raltegravir twice a day, unboosted. Elvitegravir once a day, boosted. Right now, only available in this quad form, and there's been a little bit of a delay or setback in the approval of the standalone agent. And then dolutegravir will be a once a day unboosted agent. So what about raltegravir? This is the old integrase inhibitor. It seems funny to talk about old integrase inhibitors, but it is old, I guess, by today's standards. So it's been tested against efavirenz in first-line therapy and did very well, and then at 4 and 5 years became superior to efavirenz. So you can see over time there was this sort of steady trickle of people coming off efavirenz, and finally this difference became significant. Why is that? This was a blinded study. I don't know if you can really have a blinded study with efavirenz because, you know, when people get that first wild dream on their first night, the blind is sort of busted. But in this case, it was blinded. I suspect, and I think we all see this, that we have patients who've been on efavirenz for years, doing well, but, you know, someday they come in and say, you know, I'm not quite as sharp as I used to be or at work, or I'm still kind of brain dead in the morning, or I'm depressed and I was never depressed. So, you know, that happens, and people come off efavirenz for reasons like that, and sometimes they get better, suggesting that it was an efavirenz side effect, and other times they don't, suggesting that it wasn't. But that's probably what's going on here. Now, moving on to elvitegravir. These are the data that led to the approval of the so-called quad, and that's elvitegravir, the booster cobicistat, tenofovir, and FTC. It was compared against tenofovir, FTC, efavirenz, and you can see that at 48 and 96 weeks, non-inferior. In fact, again, numerical differences favoring the elvitegravir arm, very low rates of virologic failure. Less abnormal dreams and dizziness. Now, some say, well, wait a minute. You know, elvitegravir is not supposed to cause abnormal dreams, right? Why is it, even though it's less, why is it causing abnormal dreams? Well, first of all, what's a normal dream, right? Who's ever had a normal dream? And secondly, what happens in a study like this, blinded study with efavirenz? Well, you get this consent form that talks about the possibility that you'll have all these vivid abnormal dreams and stuff. And then every time you go in, the study nurse asks you, so did you have any abnormal dreams? So of course, people being people, there's going to be plenty of abnormal dreams in a study like that. If you look at the study where elvitegravir was compared with atazanavir, no abnormal dreams. So it's just because nobody was asking, I think. Now, remember that cobicistat inhibits tubular secretion of creatinine. So it causes an elevation in serum creatinine, which causes a change in estimated GFR. It's not a true nephrotoxicity, because if you measure iohexol clearance, you don't see it. But this is what happened in this study. Efavirenz, no change in creatinine. Cobicistat, about a 0.13 change, all occurring in the first few weeks and then stabilizing. And if you looked at it by EGFR, you can just kind of see the inverse of this graph. In terms of discontinuation due to renal adverse events, it's about 1.4%, with the, and then 2% at 96 weeks in the elvitegravir arm, none in the efavirenz arm. What about resistance? Oops. We see the usual non-nuke and nuke resistance mutations when efavirenz fails. And at about the same numbers, you see primary integrase resistance and nuke resistance when the quad fails. And I've heard some people say, well, you should use quad because it's boosted. And boosted drugs don't give you resistance. Well, that only applies to protease inhibitors. So the fact that elvitegravir is boosted gives it no resistance advantages. You still can get resistance when you fail. So don't think that, for example, this patient's likely to be non-adherent, therefore shouldn't get an efavirenz regimen, so I'll use this. There's probably no significant advantage. Now, here's the other study. This was the quad versus tenofovir, FTC, and atazanavir. Again, looks very similar, great results, very little virologic failure. Here, interestingly, you see an increase in creatinine in both arms, more in the cobicistat elvitegravir arm, but you see some here, and it turns out ritonavir does the same thing, just to a lesser degree. Not something we've ever really paid any attention to. But I suppose if we go back and look really closely at our patients who start PI-based regimens, we would see this. And it turns out dolutegravir does it as well. So something we'll need to start getting used to. Resistance, well, again, this study once again shows that even though there's waning use of PIs in practice, they still have that unique advantage of being almost resistance-proof. So patients who started atazanavir and failed, no resistance. Patients who started integrase inhibitor, you did see some nuke and integrase resistance. Now moving on to dolutegravir, the third integrase inhibitor, the one that we expect to see approved this year. Here's a study comparing it with raltegravir in naive patients. Non-inferior results, excellent rapid response in viral load, and this is what you expect with any integrase inhibitor, probably based on the mechanism of action and the where it works in the viral life cycle. In terms of resistance, interestingly, unlike with raltegravir, there were no resistance mutations seen with dolutegravir. And to this date, I don't think there have been any resistance mutations seen when it's used for naive patients. It doesn't mean we won't see them. It doesn't mean it's like a boosted PI, but it's promising. That it seems like maybe there's a little bit of a higher barrier to resistance than what we see with raltegravir and elvitegravir. Now here's the study where we're looking at dolutegravir plus abacavir 3TC, and this will be the first non-tenofovir-based single tablet regimen to be approved when it comes out. So they're comparing that with efavirenz tenofovir FTC. Pay no attention to this big difference here, because that's just what you see when you compare an integrase inhibitor with anything. People's viral loads go down faster. Focus over here, and in fact, this was the first study where anything was superior to efavirenz at the primary endpoint. And so that's kind of a history-making study. Now, why was it superior? Not because it was a more potent drug. If you look at virologic non-response or failure, it was about the same. It was because it was better tolerated. More people discontinued efavirenz because of adverse events. 10% seems a little high to me. I don't think 10% of my patients discontinue efavirenz, but that's what happened in the study, and it's where the superiority came from. So it's a better tolerated drug. And again, no resistance was seen in failures, whereas there was resistance seen with the efavirenz arm. So very exciting and coming soon. Moving on to PIs. Not much new to say about PIs. Here's the PIs. Here's one where we can take the red pen and just slash through here and make your life a lot easier, right? So, all right. Doesn't that look better? Because the other ones, let's face it, we're not using those much. So those are the PIs that the fellows need to know about. Now, we don't have any new PIs to talk about, but we do have new ways of using PIs. And so cobicistat is a way to boost PIs without ritonavir. And eventually we're going to have a cobicistat standalone pill, and we'll probably have cobicistat darunavir and cobicistat atazanavir. So here's a study looking at cobicistat versus atazanavir to boost, cobicistat versus ritonavir to boost atazanavir. And you can see overall, they looked about the same efficacy, and at different subgroups of viral load and CD4, they had about the same efficacy. So it looked very comparable. Here's the kidney issues. Again, ritonavir and cobicistat both reduced tubular excretion of creatinine. So you see a rise in creatinine in both, but it's a little more with cobicistat because the effect is bigger. And here's the effect and change in GFR. In this study, pardon me, 6 in the cobicistat arm and 5 in the ritonavir arm stopped therapy because of renal abnormalities. 5 of 6 in the cobi arm versus 2 of 5 in the ritonavir arm had proximal tubulopathy and stopped therapy. So remember, proximal tubulopathy, manifested by excess phosphate wasting, glycosuria, proteinuria, is sort of a specific complication of tenofovir that we worry about, whereas the effect of cobicistat on creatinine is a different mechanism. It's just an apparent rise in creatinine. But we do worry that because both cobicistat and ritonavir boost tenofovir levels, that we could be seeing more tenofovir toxicity when you boost. At least in this study, it wasn't clear that cobicistat was any different from ritonavir, but there's always that worry that if cobicistat has a bigger effect on tenofovir levels than ritonavir, it's theoretically possible that it could create more tenofovir toxicity. But this didn't appear to be a big problem in the second year of the study. What other PI news is coming? Well, I said there may be darunavir-cobi and atazanavir-cobi co-formulations, which would reduce pill burden and copays. We hope to see a new protease inhibitor single tablet quad of darunavir-cobi, FTC, and TAF, which is called DCF-TAF, and I'm going to talk about what TAF is later. And then we're eagerly waiting results of probably the last big ACTG treatment trial, Argent, where they compare boosted darunavir, boosted atazanavir, and raltegravir. So that's kind of what we can look forward to in the PI arena. Entry inhibitors. Well, remember, there's 3 stages of entry, right? So there's binding of CD4 to GP120. There's attachment or binding of CCR5 to GP120, and then there's fusion. So we've always had this. We've had this fusion inhibitor and fuvertide. We have CCR5 antagonists. So far, we have not had anything that blocks that first attachment step, but they're working on things. So, and I'll mention them. Right now, these are the 2 entry inhibitors that we have. And there are several new entry inhibitors coming, a new CCR5 antagonist that has anti-CCR2 activity, which may reduce inflammation. That's at least the hope. There's a BMS CD4 attachment inhibitor, and there's ibalizumab. I've learned to say it now without stuttering. And it's anti-CD4 monoclonal antibody that would be given infrequently and possibly may have some role in prevention as well as treatment if that makes it all the way through. All right, nukes. Here's the nukes. Let's get rid of the ones we don't like. That leaves us with 4. The rest are of historical interest or interest outside of the US and developed countries. So these 4, and I've given some comments about them. Of course, each of these is available in multiple different forms, and some are available generically. Now, there's still there's issues with both abacavir and tenofovir. We do not have the perfect nuke, that's for sure. Abacavir was shown in the ACTG 5202 study to be more dependent on baseline CD4 and viral load than tenofovir. You can see that tenofovir was tightly clustered regardless of baseline viral load and CD4, whereas there was more difference in efficacy with abacavir depending on what your baseline numbers were. And this was one of the reasons it got sort of moved to alternative for a while in both sets of guidelines. Then there's this question of MI risk. So there was the original DAD study that suggested that abacavir was associated with a higher risk of MI. Then there were other studies that said it wasn't, and there were others that it was, and it wasn't, and it was, and it wasn't. And I haven't shown all those. Now I'm showing the new ones that also say it is, it isn't, it isn't. And I like this line from the editorial. How difficult it is to find a consensus can be exemplified by the fact that even identical data sources from the VA analyzed by different investigators lead to conflicting results. So VA study, yes. VA study, no. As far as I know, it's pretty much the same patients, same data, but different investigators. So I don't know. The answer is I have no idea whether abacavir increases your risk of MI. What can we say? The data are conflicting. There are some proposed pathogenic models that have some data to support them, but they are still just models, and they include all of these things here. So I can only agree with the guidelines. They say use with caution in patients with high cardiovascular risk, basically until we know the answer. Will we ever know the answer? I don't know. There are still a few big cohorts out there that haven't been heard from, so we'll see. I will say this about the viral load issue. And that is that in the dolutegravir study, viral load didn't seem to matter. So the viral load issue may not be an issue in combination with dolutegravir, and that puts at least one of the concerns to rest about abacavir. Now, tenofovir is not without its blemishes. We know it causes kidney disease. This was a study, again, from the VA that looked at time to first occurrence of various forms of kidney disease, proteinuria, rapid decline in kidney function, and CKD. And they found that every year of exposure to tenofovir gave you about say a 33, 34% increased risk, depending on which of these endpoints you're looking at. Now, when that got published and there was a press release, it got widely misquoted as saying that your risk was 34%. But that's not the correct way of looking at the statistics. So let's say your background risk is 1%. If you're on tenofovir, that makes it 1.33% per year. Still low risk, but an increase. And of course, it's cumulative. So every year you're exposed, you have this increased risk. I mean, I think we're all pretty familiar with that. We're also familiar with sort of the creatinine creep that we see as patients get older and are treated with tenofovir. And we're never quite sure, is this tenofovir doing this? Or is it just their age or their other risk factors? And you often don't know, but sometimes have to make changes in therapy as a result. Then we've got bone data. We know that tenofovir causes a greater reduction in bone density than other nukes. It tends to occur early on and then stabilizes, but it is more. And we know that if you switch from AZT to tenofovir, you get a further reduction. And that if you switch from tenofovir to raltegravir, you get an increase in bone density. So I used to tell our staff would say, well, we have this patient, she's got osteopenia, and she's 65 years old, and she's on tenofovir for 10 years. Should I switch? I said, well, the damage, if there is damage, has been done. There's no point in switching. But this study would suggest that, in fact, there may be a benefit in such patients to switching. Now, TAF, tenofovir alafenamide fumarate, is a new prodrug of tenofovir that we hope will have less of these problems. So what happens is it gives you higher intracellular levels but lower plasma levels. You can use very tiny little doses and you get greater viral load reduction. Here's a study comparing L-vitagravir, cobicistat, FTC, and TAF versus tenofovir. So these are two different quad pills, one containing the usual tenofovir and one containing TAF. And they found equivalent viral load response. They found, interestingly, a little better kidney, a little lower change in creatinine with ECF TAF for reasons that aren't entirely clear. And then a better reduction, less of a reduction in bone density at 24 weeks. So here's TDF and here's TAF, virtually no difference from baseline. So this is promising. Phase 3 trials are now ongoing. They're also going to be taking people who have had to come off tenofovir in the past for renal function and putting them on TAF to see how they do. So they're going to kind of use the patients who are at most risk and see whether this is safe from a kidney standpoint. So it could be that we will not have to be worrying about this too much anymore, but we'll see. So single tablet regimens. Should everybody be on a single tablet regimen? Here are the three we have right now. Here's the one everybody voted for. the old standard for first-line therapy. Has the advantage of PK being very forgiving of missed doses. It does have a lot of weaknesses, though. The CNS side effects, teratogenicity, a big risk of resistance with interruption because of the long half-life, the rash, and the lipid effects. These ones do have advantages. Rilpivirine is extremely well tolerated, but has its weaknesses in terms of viral load and food requirements. The elvitegravir Cobi looks great, but you do have to know about the Cobi drug interactions, which are similar to those of ritonavir, as well as the effect on EGFR. And then we've got the new single tablet that will be coming, abacavir 3-TC DTG, or dolutegravir, which will be the first time we'll have a single tablet for somebody who can't take tenofovir, which has been a limitation, and is the first one to show superiority to efavirenz. There'll still be this lingering MI issue that we haven't solved yet. Question. In a patient at high risk for non-adherence or treatment interruption, what's your usual approach to initial therapy? I prescribe the simplest and best tolerated regimen possible, preferably a single tablet regimen. I prescribe a boosted PI to minimize the risk of resistance, or I prescribe a boosted integrase inhibitor to combine simplicity with a high barrier to resistance. I think I gave away that answer already. All right. Interesting. Okay. So pretty much even. And I would say among experts, I find the same thing. There's the experts, maybe I'm in this camp that says if somebody's likely to interrupt therapy, they should be on a PI because they can't screw it up. And others say, why would you give multiple pills to somebody who's likely to screw it up? It's a hard one. I don't know the right answer. But there's something to be said for both. Now, this one is interesting. As I said, just the fact that it's boosted doesn't mean it's got a barrier to resistance. So you could argue to prescribe this because it's simple, but I'm not sure you should argue to prescribe it because you're not going to get resistance, because we just know that's not true. So if you're in this camp, you could prescribe the efavirenz regimen or the elvitegravir regimen. If you're in this camp, you're going to prescribe a PI. So why would you ever prescribe more than a single tablet in 2013? Let's say based on what we have now. Well, why would you prescribe boosted PIs? Well, you know, I just saw a patient admitted for the first time in our inpatient unit, history of substance abuse, mental illness, pneumocystis, CD4 is, 5. We know the data show he'll live longer and less likely to die if we treat him while he's in the hospital, but we have no idea if we'll never ever see him again. So I personally think it would be crazy to prescribe efavirenz or elvitegravir to this guy. So we gave him a boosted PI and tenofovir FTC because if he goes out and doesn't take his meds, it's not the end of the world. He's not going to get resistance. So that's one reason. Transmitted resistance to nukes or non-nukes is another common reason, and then, of course, pregnancy. What about raltegravir? I think there's less use of raltegravir now, but it still has the advantage of having essentially no important drug interactions. With dolutegravir coming, that will also be true of dolutegravir, though. Abacavir 3-TC and a third agent, I think clearly appropriate for patients who start out with kidney disease or bone disease, the person who already has baseline osteopenia or osteoporosis. Nuke-sparing regimens, this is a hard one because we know there are patients who have contraindications to nukes, patients who have baseline nuke resistance, but we don't really know what to use except we know we need to maybe avoid nukes in those patients. Pregnancy, let's look at just kind of special scenarios. In pregnancy or likelihood of pregnancy, we're going to avoid efavirenz. I think a lot of people look at the CDC categorization for drugs like rilpivirine or elvitegravir. They say it's category B. That sounds great. But remember, we don't have any data on these drugs, and you're much better off sticking with what we know. And these are the drugs that are okay according to the perinatal guidelines, which I think are a better source of information on how to treat pregnant women. Hepatitis C, well, this is kind of obsolete now because probably not many of you are using telaprevir or boceprevir. There was a time when we were using them and we had to think about what drugs we could use with them, but now everybody's kind of waiting for the newer, better drugs that are coming very soon. Hepatitis B, of course, you're going to want to use tenofovir FTC if at all possible. Chronic kidney disease, avoid tenofovir, and frankly, there's now some data that atazanavir and possibly even lopinavir may be associated with renal dysfunction. So keep that in mind as well. It may not always be just tenofovir. Pre-existing osteoporosis and osteopenia, of course, avoid tenofovir. Need for urgent ART without resistance data. The patient comes in with primary infection and you want to treat. Use a boosted PI until you get that resistance test back, because you're very unlikely to have been infected with a virus that's resistant. And then new formulations are coming. We've got 3 single tablet regimens, more are on the way. Other possible co-formulations are coming. But of course, generics are also coming. So we may not always have the full array of drugs available to us to prescribe unless we want to do a lot of paperwork. So we'll see what happens with, especially with generic efavirenz, whether we get pushed to sort of prescribe generics unless there's a really good reason not to. Just briefly about treatment-experienced patients. This dates me. Of course, this album cover was before HIV existed, at least in our understanding. Elvitegravir compared to raltegravir in treatment-experienced patients looked just as good. I won't go into the details. Interestingly, though, dolutegravir looked superior to raltegravir in treatment-experienced patients. An unexpected finding. So again, dolutegravir superior in naive, superior in experienced. Unusual for us to see those kind of results. Second line, we often wonder what to do for second line therapy. Of course, a lot of the patients in our country who fail first line are non-adherent, so a lot of times that drives the decision. But it's a real issue in resource-limited settings where they don't have genotypes. This was a study where they compared moving to a boosted PI with nukes versus a boosted PI with raltegravir and found no significant difference, that both were acceptable. But of course, here you would generally use a genotype to help select your second line. Here's a final question, I think. In a highly experienced patient with multi-class resistance, do you include nukes in the salvage regimen? Yes, even if they have extensive nuke resistance. Not if they have extensive nuke resistance. Depends on the number of active drugs in the regimen. Or I've forgotten everything I ever knew about designing salvage regimens. Okay? All right. So, good. I think that 46% of you got the right answer. It does depend on the number of active drugs. And this was shown in the options study where they took patients who were failing multiple classes of drugs, but who had more than 2 active drugs available to them, not including nukes. So they could have 2 plus partial activity of PIs, for example, and they were randomized to get nukes or to not get nukes, and the nukes would be chosen based on genotype and phenotype. And what they found was that having the nukes on board did not make any difference. The people did just as well without them. In fact, there were more deaths on the nukes, though it didn't appear that it was due to the nukes. So I think the conclusion was that you don't need, there's nothing magical about nucleosides. You don't need them if you've got a fully active regimen without them. So I will stop there. Picture of Baltimore, and I'm happy to take questions. Thank you. Joe. So for those in the other room, Joe's saying that the cost of generic efavirenz is going to be a tiny fraction of what the cost of the brand name is, and how could we not use that as our go-to regimen? And I think you're right. I think when the price is that much lower, given the financial constraints we're under, I think that will be what we're going to be told to use. Now, you know, even though I think there's clear advantages of some of these other drugs, the advantages are not so great that they outweigh the cost benefit. So I suspect that what's going to happen, we're going to put people on efavirenz, and those who develop CNS toxicity will be filling out prior authorization forms and things like that to try to get access to the other drugs. You know, I think I don't see any possible other way around it. I think both in terms of government payers and third-party private payers, that will be what will happen. You know, it's never happened before because we've never had a good generic drug before. This is a good generic drug, so it'll make a difference. Yeah.
But Joe, I think that makes a lot of sense versus 36% allowance.
Yeah. You know, so the question is, what about the people who really should be on PIs? And will we really have to use efavirenz in everybody? And I worry about that more than I worry about whether I can prescribe elvitegravir or rilpivirine, because I think that for a lot of people, and I certainly look at almost every patient on our inpatient ward is on a boosted PI for that very reason. They're just not reliable enough to take anything else. And I worry that if we have to go through a lot of work to be able to prescribe PIs, which, by the way, are the most expensive regimens we use. They're more expensive than elvitegravir. If we have to do that, a lot of people won't bother, and they'll just prescribe efavirenz to people who have very low likelihood of doing well and will develop resistance very quickly. It's a big concern. All right. Thank you, everybody.